Eileen, thank you for the introduction, and thanks for the opportunity to be able to present today. Thanks to Liz Gilliams and all of the other people who are taking part in this presentation. So first, I'm going to hand over to Dr. David Blythe, who is the State Epidemiologist and Director of Infectious Disease Epidemiology and Outbreak Response at the Maryland Department of Health.
Great, thank you, and good afternoon, everyone. Happy to join you today, and I'm going to run through some information here, but I'd sure be great to be able to answer questions. And some of what I'll run through, I wish I could provide more details. Some of it is information I won't be able to share, but I'll try to share what I can. So first of all, as you guys probably well know, globally, with the eradication of smallpox back in 1980 and the subsequent cessation, broad cessation of smallpox vaccination, monkeypox has emerged as the most important orthopox for public health. As I think probably all of you know, there is still, even before this particular monkeypox outbreak, there was still smallpox vaccination occurring in certain groups, and in particular, most recently in the U.S. military, but also in laboratory workers and others. But the broad and widespread vaccination had ceased. And you probably will also appreciate that monkeypox primarily occurs in Central and West Africa. And the cases are often in proximity to tropical rainforests, but really has been increasingly seen in urban areas, and particularly in West Africa and in Nigeria. And it's unclear exactly how people are exposed in those endemic areas. And there have been attempts to try to identify rodent vectors, and so they've looked at like squirrels, Gambian pouch rats, which served as the vector for the outbreak that occurred in the U.S. back in 2003. But anyway, other rodents, dormice, and then non-human primates and other species have been looked at, and they can be infected, but what role they play in the ongoing transmission in endemic areas is still unclear. And in terms of the case fatality ratio, it really depends. I haven't mentioned, but as you guys probably well know, there are two clades. There's a West African clade and a Central African or Congo Basin clade. And case fatality ratios have differed depending on the clade, and there might be reasons to think that that's partly related to the virus and also partly related to the locations and underlying disease of people who are being infected in those regions. But anyway, what's reported, at least what had been previously reported, was 3.6% case fatality ratio for the West African clade, so much lower than in the 10% case fatality ratio reported for the Central African clade. And in the United States, there's transmission really occurring throughout the country. And you can see here the map from a couple of days ago from the CDC, and this also lists case numbers. And I won't go into great detail with the case numbers. They're occurring throughout the country, and particularly in some of the urban centers, but especially in the Washington, D.C. region. So Washington, D.C. itself has the highest rate of any place in the United States in terms of new monkeypox cases. But in Maryland, we have, as of this morning, actually 71 confirmed cases. And the case numbers just keep increasing at a really pretty alarming rate. And so over the course of the week, and each week, we're essentially doubling case numbers from week to week. So we'll be keeping a close eye on that. But anyway, there are still some jurisdictions that have reported at least low numbers of cases, but I think this will soon be established throughout every state in the United States. And next slide. So just to get back to this, our first case was identified back in the middle of June, so just over a month ago, but our first case in this particular outbreak, we actually had a case last November in a traveler who returned from Nigeria, but in this particular cluster, as of 2 days ago, we had 55 cases. As of this morning, we have now 71 orthopox positive cases. And as a state, we're approximately the 12th highest jurisdiction in the U.S. But as I mentioned, cases are not evenly distributed throughout the states. And so particularly in the National Capital Region of Maryland, associated with D.C., but also in the Baltimore metro area, we have the concentration of the cases here.
Thank you so much.
Matthew, yes.
Thank you so much, Dr. Blythe. Appreciate that. I'm sure there'll be questions later on, so if you're able to stay on the call, that would be wonderful. Thank you. So I want to spend just a few minutes thinking about some of the clinical features of monkeypox. And as most, if not all, will be aware, the CDC case definitions, there are CDC case definitions which are listed here. We're dealing with suspected through confirmed. The confirmed cases of monkeypox are those where a monkeypox DNA, PCR, or next-gen sequencing test is positive from a clinical sample, or if monkeypox virus is isolated in culture. The epidemiological criteria are listed here, and they state that within 21 days of illness onset, that the individual reports being in contact with somebody with confirmed monkeypox or with a rash that looks like monkeypox, or who's had close in-person contact with individuals in a social network experiencing monkeypox activity. And this includes, but is not, isolated to men who have sex with men, particularly those who meet sex partners online or at social events such as sex parties. Also includes transgender women and people who are involved in commercial sex. Or those who travel outside the country to an area that's endemic. I think that's much less important. Recently, the cases that we've been seeing appear to have been acquired within Maryland. And then lastly, if they've had contact with a dead or wild animal or product. Monkeypox can be excluded if an alternative diagnosis can fully explain the illness, or if the individual does not develop a rash within 5 days of illness onset, or where a high quality specimen is negative for orthopox or monkeypox DNA on PCR. The natural history of monkeypox is that the incubation is between 5 and 21 days. It's usually between 7 and 14. During that time, the person is deemed to be non-infectious. This is followed by a prodrome, and there's some debate about infectivity during this prodromal phase, which consists of fever, malaise, headache. Sometimes people will have a sore throat and a cough, and they will develop lymphadenopathy. And it's said that the presence of lymphadenopathy distinguishes monkeypox from smallpox. Lymphadenopathy usually comes on with fever onset, and that's 1 to 2 days before the rash becomes evident, or less commonly, lymphadenopathy comes on at the same time as the rash. So following the prodrome, the lesions will develop in the mouth or on the body, and then these lesions will progress through several different stages before scabbing over and falling off. A person is considered contagious from the onset of the first skin lesion until all of the lesions have scabbed over and new skin has regrown. Monkeypox may scar or may leave hypo or hyperpigmentation after resolution of the rash. So classical monkeypox begins with a prodrome, as I've just described. The distribution of the skin lesions are centrifugal, and there is regional monomorphism of lesions. And you can see 2 images there that demonstrate this. People who've received smallpox vaccination in the past tend to have fewer and smaller lesions. During the current outbreak, there are some images on the left of the screen that are available from a link by a Spanish group, and that the lesions are vesicular and pustular. Typically, on examination, they feel deeper than, for instance, a herpes or a syphilitic lesion. They can be umbilicated. They're typically painful, and they can be very painful, and that itching occurs during the crust phase. Most commonly, lesions will resolve after 2 to 5 weeks. However, there are some clinical differences between classical monkeypox and the presentation that we're currently seeing. And the main differences are that the rash is seen in genital, perianal, and oral areas. And there's a question about why this occurs, whether it's because it's the site of exposure, whether it's due to the inoculum. But in this current outbreak, we're seeing people with no involvement of face or extremities. And the other feature is one of anorectal pain, tenesmus, and other anorectal symptoms. And also the prodromal symptoms are not consistently observed before onset of rash. And I've certainly seen a patient who developed systemic symptoms the day after they first developed a rash. I want to share briefly 2 experiences from London in the UK. The first is from the Chelsea and Westminster group of clinics, and they described their experience between May 14th to the 25th. They described 54 cases who are all men who have sex with men. 70% of them were white, and 24% were living with HIV. Most described fatigue and lethargy. 60% almost reported fever, and 18% had no prodromal symptoms. Almost all lesions were anogenital, and 4 had oropharyngeal lesions. Just over 50%, so only 55% had lymphadenopathy, and importantly, a quarter had a concurrent STI. 9% required hospital admissions, and this was either for pain management or for intravenous antibiotics for bacterial cellulitis. Only 1 of the patients received tecovirimat. And these are some images from the Chelsea and Westminster group experience. And you can see on the left the evolution of the perianal lesions, and on the right the image of the penis with the multiple non-coalescing lesions on the prepuce, and then this large coalescing lesion at the coronal sulcus. The second London experience, these are unpublished data describing 133 patients between May 10th and June 24th. 38% of this cohort were living with HIV, and 30% had an STI at the time of their monkeypox diagnosis. In terms of systemic symptoms with respect to rash, then 53% had systemic symptoms before the rash, and 35% after the rash had already occurred. Again, there was the majority of lesions were genital or anal, perianal. 34% had rectal pain. 4 had severe proctitis on imaging, and 1 had a rectal perforation. One of the features that this center described is penile edema. So 15% had penile edema, and unfortunately 1 person had Fournier's gangrene. 12% had to be admitted, and again, this was for pain management and for the management of genital edema. And 6.8% of this cohort received tecovirimat. The differential diagnosis of monkeypox is broad. I've listed some examples here with primary and secondary syphilis as demonstrated on the top 2 images, varicella and disseminated cryptococcal infection on the middle 2 images, and then at the bottom, disseminated gonococcal infection and molluscum. And then, of course, there are all of the other typical or and less common causes of genital and anal ulceration and proctitis, and some of those are listed here. So just to end, after you have seen a patient and have a preliminary or provisional diagnosis of monkeypox based on history and exam, then patients are advised to isolate at home, to wear a mask, to avoid animal contact, that household members should undergo hand hygiene regularly and avoid sharing anything, so any fomite that could facilitate spread of infection. So with that, I'm going to hand over to Dr. Mostafa to talk about diagnostics.
Thank you, Matthew. Hi, everyone. I wanted to just give a very brief overview on orthopoxvirus testing that we developed here in the lab. Next, please. So just a very little about the virus. So poxviruses, those are large genetically complex viruses, and they have this very characteristic shape, the prick shape or ovoid variants, that is very characteristic with electron microscopy. And this is why this has been like a very good way to identify those infections, but this is not really a lab way of diagnosis because of how complex this technique is. But the viral genome is very large. This is the genome can actually be more than 200 or encode for more than 200 polypeptides. And very unique about this virus that it actually does all its replication steps within the cytoplasm. So it packages a lot of proteins within this viral particle. Next, please. And this is the taxonomy of the poxviruses that can infect humans. Just wanted to touch base on this because of the nomenclature of the different assays available. So you can see that the orthopox virus genus contains the variola, vaccinia, cowpox, and monkeypox species. And this is why the orthopox virus assay can, practically speaking, detect different viruses or different species. And then you can see that there are other poxviruses that belong to different genera within the poxviridae. Like, for example, ORF, which is very common poxvirus that can infect humans. This belongs to the parapox virus, and also molluscum contagiosum virus is a mollusky poxvirus. So relevant to this topic or today's talk, the orthopoxvirus infections is where monkeypox virus species belongs to. And then the assays that have been discussed were either orthopoxvirus assays or monkeypox specific PCR. So the orthopoxvirus specific assays can then detect different species. But then the assay we developed in the lab, which is the non-variola orthopoxvirus assay, this one will not be able to detect variola, as I will touch on in a minute. When we started to think about bringing the test to the lab, it was very important to think about the lab procedures and the biosafety. And this is really, those are the guidelines through the CDC website. So we thought about the process and from two large kind of categories from a specimen perspective. So there are those specimens that will be submitted for general testing, which are called non-lesion specimens through the CDC website. For example, if the patient requires urine analysis, chemistry, and so on. And then based on the CDC guidance, the quantity of the virus which is likely to be in those specimens is usually low. So they did not recommend the vaccination of the staff, and they just recommended standard universal precautions when we handle those kinds of specimens. Next, please. Then when we talk about the specimens that come from the lesions themselves, and this is where the highest viral load is expected. And this is relevant for both monkeypox or orthopox specific testing, and also any other differential diagnosis like HSV or VZV. Those then, because they have this highest quantity of the virus, so the CDC recommends that when possible, vaccinated staff should handle the specimens and perform testing. But if this is not available, then we should add an additional layer of precautions. So in the lab, we decided to use BSL-2 practice, BSL-2 containment with added BSL-3 practices like adding face shields and additional measures that we used actually for COVID-19 testing. Next, please. So the testing that we do, this is a PCR-based testing. Molecular-based methods really is the preferred method for diagnosis. But just wanted to highlight this comment from the CDC about the specimen collection, because this is kind of a tricky or like an important step that might expose healthcare providers to high-load virus containing specimen. So they recommend that if you are caring for a suspected patient, wear a fit-tested N95 respirator. And then the personnel who were previously vaccinated, those are better to collect the specimens. But if this is not available, then you can then take additional precautions. But if smallpox is confirmed, then the personnel who were collecting the specimens should be vaccinated immediately. So I highlighted this here, and maybe Dr. Blythe can give us some perspective about this at the end of the talk. Next, please. So those are the specimens that are could be collected for diagnosis, and they are divided in this table from the CDC website based on the disease stage. But really, what we are accepting in the lab has been those lesions, including lesion fluids and swabs. The CDC accepts also the lesion scabs and the crusts for diagnosis, and those can also actually contain very high viral load. Next, please. So just very quickly about the assay that we are running here. This was an assay that was developed by the CDC back in actually, I think it was developed prior to this date, but it received FDA clearance, I think, in 2018. The assay detects non-variola orthopox viruses. So practically speaking, the only other virus that can be right now in the US or in North America be detected by this assay is vaccinia virus-related infections associated with vaccination. So really, we can consider this as, say, a very specific assay for monkeypox right now, if we can exclude this possibility of the vaccinia virus infection. Next, please. And when the assay was verified, and also we did additional testing here in the lab, you can see that comparing this in here, this is actually showing the specificity of the assay or non-variola orthopox assay for different species of orthopox viruses, and you can see that it does not detect variola. It can detect some vaccinia viruses, and it can also detect all of the monkeypox viruses that were tested. Next, please. And this is just a continuation of this evaluation, showing that the assay is very specific. When we tested it against herpes, VZV, we did additional testing with other pathogens that can cause similar lesions, and it is actually very specific. Next, please. And this was a comparison between the performance of the non-variola orthopox virus test versus a monkeypox specific test from this one publication. And you can see that the performance was very similar, and also the CT values, which kind of a reflection to the relative viral load within the specimens, were also very comparable. Next, please. This is a recent publication, an MMWR from the CDC, that discussed kind of the response from the CDC to the monkeypox outbreak from a diagnostics perspective, and their efforts to actually expand the testing for monkeypox nationwide. And actually, I sat in several discussions on ways to increase the capacity of testing. And the CDC really was very helpful in sharing their protocols, sharing also their kits and the labs that can actually perform the testing using these kits. This table here shows what the CDC tested between May 17 to June 30. You can see that they tested quite a large number of specimens, and at this time, the CDC could handle, or actually not the CDC only, all the lab response network labs, they were able to test about 8,000 specimens per week. And you can see that their turnaround time from the specimen received to the CDC was an average of 30 hours. But this actually excludes the time which is needed upfront between approving the testing by the state labs and sending the specimens to the CDC. So this was one of the reasons why we really wanted to bring the testing in-house quickly and offer it to be available for providers to order freely as a part of the differential diagnosis without a requirement of any pre-approvals to order the test. Next, please. And as part of the efforts from the CDC to expand testing, they actually now worked with 5 large state labs to help them establish the testing, to increase the testing capacity to about 10,000 per each of these labs. And the top 5 labs here on the right side, AG's LabCorp, Mayo Clinic, West, and Sonic Healthcare, were the 5 labs that are now live with the testing as reference labs, which I think now brings up the capacity of testing in the US through the lab response network and the reference labs to about maybe 60,000 per week. And I just noticed this week that ARUP labs are also live with their testing. And the commercial testing available, there are actually not very many options right now. I'm aware of those couple of tests that were communicated with us through the companies. A kit from a company which is called Altona, and a kit through Roche in collaboration with LightMix I don't know exactly which LightMix modular virus kits. But right now, the test we are actually running in the lab is the CDC assay, but we have developed it as a lab-developed test. As of yesterday, we tested 31 samples and we diagnosed 10 positives. So thank you.
Thank you so much, Heba. Thank you for all of your excellent work in the lab. The fact that we have an in-house test, it makes it so much more efficient for us. Just really, really grateful for that work and that you've been working closely with MDH on that. So thank you. So I'm Joyce. I'm the interim medical director at the Bartlett Specialty Practice, and I'm going to go through our clinic's workflow, which we took really from Liz Gilliam's and what she put in place at BCHD and modified it for our clinic. So I have many people to thank. This has been a surprise, I think, for all of us, and just everyone getting together to work things out has been really helpful. So if a patient calls the clinic and they have a new rash or they're concerned that they might have a monkeypox infection, we have nurses who will do the triage, get the clinical information, and then consult with the patient's primary provider. Or if the primary provider is not available, one of our attending or acute providers, to decide if an in-person monkeypox evaluation is warranted. If it is warranted, the nurse arranges to meet the patient. They will be wearing their full PPE and bring them into the designated clinic room for the monkeypox evaluation. Next slide. If the patient is identified in clinic that they have a new rash or they are concerned that they have monkeypox, again, they get immediately put into that designated clinic room. Next slide. So then when the patient is in the room ready for an evaluation, anybody who's going to be working closely with the patient should be wearing the full PPE. So a hospital approved respirator, N95, typically a face shield, hospital gown, and gloves. And then our clinic workflow, we have a nurse working closely with the provider doing the evaluation. It's really the provider who's doing that evaluation, who will decide if monkeypox testing is warranted. If there's another reason for the patient's symptoms, this is not monkeypox, the patient will be moved to a regular clinic room and everybody will be notified that the patient is not a suspect for monkeypox. If it's decided that, previous slide, if it's decided that the patient should get tested, then what, recommendation is to really decide ahead of time what is going to be sampled. Take pictures if you can through the Haiku app and with the patient's permission. And then it's really one test that's ordered in Epic, and then multiple labels should be printed for the number of specimens that you collect. And then identifying on those labels the anatomic site and a description of the lesion when you put those on the tubes. So those get collected. Any other testing you should be doing, HSV, VZV, syphilis, gonorrhea, chlamydia, those should be ordered as well. And then once everything is collected, the provider will give the patient their isolation precautions in their plan. The nurse will take the specimens for anything that's been collected off of the patient's body need to be hand delivered to the lab, and the lab is notified that it's a patient who may have monkeypox. So for the monkeypox labs, they're double bagged, they get taken to Heba's lab in the Meyer basement. The gonorrhea, chlamydia tests, those get hand delivered to microbiology, again, notifying the lab staff that this is a monkeypox suspect. The phlebotomist will then come in donning full PPE and draw the blood specimens for testing. Those, as Heba noted, those can be sent through the usual pneumatic tube system for processing and testing. And then once the patient is ready to go home, the nurse will accompany the patient out the back door, and then the room can be cleaned with the sporicidal orange top bleach wipes, and then immediately ready for use. Next slide. For patients who need an ED evaluation, the provider should call the ED, let them know it's a patient who may have monkeypox, and the patient gets escorted by the nurse wearing the full PPE to the emergency department, and then the emergency department will make the determination about testing and do the testing themselves there. Next slide. Okay, so I already mentioned about ordering the test. When you order the test, there are some helpful information in that. There's Agile clinical guidelines, there's links to the CDC. There's automatically a rule out monkeypox flag that will go on the patient's chart once you place that order. It automatically falls off if the order is discontinued, if the test is negative. If the test is positive, it triggers automatically a monkeypox flag on the patient's chart. And then you need to contact HEIC if you need to manually remove the flag. Next slide. Okay, so the turnaround time for the orthopox virus test at Hopkins is it's 24 hours. I had a patient I tested on Friday, and I don't know if this has changed, but they weren't doing the test on Saturday, so it ran on Sunday. Only one result is reported, and as I think Heba mentioned, they do pooled testing, so aliquots from the viral media get pooled, tested here. If that's positive, the specimens go to MDH. MDH does orthopox testing again, and then it sounds like 1% of those will go to, of those positives go to the CDC for monkeypox specific testing. If the test comes back positive, between, a lot of times it's acute provider, a lot of times it's Kelly Jibo, right, who's seeing your patient and diagnosing the patient. Between the acute provider and the primary provider, whoever is in the best position to call the patient, let them know about the result, give them, answer their questions, reinforce the isolation precautions, and then let them know what's to come. So what's to come is MDH will contact the patient, do contact tracing, talk about vaccination of close contacts, and they monitor the patient until isolation can be discontinued. The process for ordering, treatment, which I think Liz is going to go through more about that clinical scenario, but if you have a patient for whom you think that tecovirimat would be helpful, right now, and I'm so glad Dr. Blythe is on the call. Dr. Blythe has been really great also working with the lab and with our clinical folks about ordering treatment. A request goes through MDH. MDH makes the request to the CDC. If that's approved, the way that the medication is designated right now is it's under investigation. So there's some paperwork involved that is a little bit complicated. And I'm going to be identifying people in the Bartlett Clinic who will be the people that if a prescription is warranted, then we'll have folks who will do that process and be able to expedite that until the classification of tecovirimat changes. And we can also arrange to have the medication delivered to the patient's home. If the test results as negative, then again, contacting the patient, letting them know it's a negative result, they can discontinue isolation, and then letting them know about next steps. Next slide. And then I put on this slide, I think we should be able to share these slides, just these important phone numbers to call. BCHD, acute communicable diseases, can take calls about close contacts who have not been yet contacted through contact tracing about vaccination, so their number's there. And then the MDH number is there, as well as Liz has emailed CDC directly with some questions and apparently has had a good response.
Thank you so much, Joyce. That was great. I'm going to hand over to Liz Gilliam now to discuss treatment and vaccines.
Yeah, thanks, Matthew. Hi, everyone. Just also want to introduce myself. I work at the Bartlett Clinic. You may see me from Monday mornings, but I also work most of my time at the Baltimore City Health Department Sexual Health Clinics as the medical director for STI services. And we have really, it's been a great experience collaborating with everyone who's been interested in this. And I'll be talking about treatment and vaccines. I'm going to move forward. All right, talking about antivirals that exist. I want to also just take a step back that many cases identified with MPX will have a self-limited illness and will not require hospitalization and or need more than supportive therapy. However, there are situations when it can be helpful. There are currently no FDA-approved treatments specifically for MPX, but tecovirimat, or also the brand name called TPOXX, is being considered and being used now to help support patients who need extra support, and is available through the CDC under what Joyce mentioned as an expanded access investigational new drug protocol. That others may know that as compassionate use. It is an oral, available orally or as an IV modality for a course of 14 days. The oral course, it's recommended to take within 30 minutes after a full meal with moderate to high fat. But there's limited sort of real world efficacy data for this current outbreak, but I'll talk a little bit in a couple slides about why we think it can be helpful. Other options for antiviral treatment that come with downsides, knowing that many of these cases will be managed in the outpatient setting, are vaccinia, IgIV, of course, is an IV option. Cidofovir comes with many toxicities, also IV, and brincidofovir is not available currently in the strategic national stockpile. So really tecovirimat or TPOXX is our main option as oral therapy for outpatients and even inpatient as well, for those who can tolerate oral therapy. TPOXX is considered for treatment for people who have either severe disease, they're hospitalized, they're requiring additional management because they're either dehydrated or have hemorrhagic disease. However, that's not been seen in the vast majority of cases with this outbreak. And it's also considered for people with at risk for severe disease. And that category includes people with severe immunocompromise, and they do call out people living with HIV. However, I'll say many people living with HIV with an adequate immune response and are on ART. It's not an 100%. It's not every person with HIV may need it to recover, but if this is someone who with a very low CD4 count, they're not on ART, and you're worried about their immune status, that may be a reason to seek out tecovirimat, or for other reasons I'll talk later about. Other reasons for considering therapy: people with exfoliative skin diseases, atopic dermatitis that may be at risk for complications, pediatric, pregnant, or breastfeeding patients. And then especially I highlighted in red, the main reason that it's being used really is people with lesions in anatomic areas that may constitute a special hazard. Either it's self-inoculated to perhaps the eye or other very hazardous locations, or that they've had quite a bit of pain, and especially around perianal and genital lesions. And that's really what I would say, and David Blythe can back me up on this, is probably the vast majority of how tecovirimat is being used. Next slide. So a few words about efficacy. We know that tecovirimat's a p37 envelope protein inhibitor. It has been efficacious in preventing lethal orthopox virus disease in numerous animal models. There has been experience showing that it can reduce lesion count, viremia, and oral viral shedding in early treatment of variola in a primate model. And that's really the foundation of how it is expected to support patients, and perhaps shortening course, reducing ongoing development of lesions during their disease course. However, a lot of that is still unknown and is part of the current experiences of the data that needs to be collected. Next slide. So we just discussed about how to get tecovirimat, and certainly I've also been on several emails. There are going to be more internal GHH system procedures that are being planned. But as we wrap up here, others who've had direct experience, especially Chris Lippincott and Jason Fairley, can share their experiences. For us at the health department, it was a pretty direct experience where it was shipped directly to us and we just handed it off to the patient. So that was a pretty straightforward process, though it does require paperwork. Next slide. I do want to prepare folks to know that if you're considering tecovirimat, I would consider it at the time that you're assessing the patient, and consider, would this be someone who would be eligible for it? Think about that at the back of your mind. Are they having severe pain? Could they need it? Know that communicate with the patient that if you're considering tecovirimat, they will need interval assessments at day 7 and day 21. This can be done remotely. There's quite a bit of paperwork that need to be completed in a certain timeline. But I also hear that this process, there may be updated procedures that the CDC is releasing. But this, again, is another opportunity for interacting and perhaps pairing with research projects as well. Next slide. So talking about vaccines, the 2 vaccines that are available for addressing MPX right now are Jynneos and ACAM2000. ACAM2000, folks may remember this. This is the traditional smallpox vaccine that's been out there. ACAM2000, it's the picture at the top right of the slide that you may remember as a little fork, and you have to do the scarification process to induce vaccine take in the skin. It is a live replication competent vaccinia virus, and so it comes with several complications from that. It is under expanded access IND for MPX as well, so it has not been pursued, I think, for that reason and others for broad public health strategy at the moment. But the main other concerns are the contraindications, because folks who have congenital or acquired immunodeficiency disorders, including HIV of any immune status, cannot receive this vaccine. And there are also risks for cardiac disease, eye disease, and people with atopic dermatitis or eczema cannot receive. And there is risk for household contact transmission of vaccinia. Jynneos, on the other hand, it's a live non-replicating vaccinia virus. It is administered as 2 doses 4 weeks apart. It is FDA approved for people who are 18 and above is under EAIND for those under 18 right now. There's no current data on efficacy in the current outbreak. And really the only contraindications are people who are currently experiencing MPX symptoms or have a severe allergy to egg, Cipro, or gentamicin. Those are components that are used in preparation of the vaccine. And it is safe to administer to people living with HIV and atopic dermatitis. Next step. All right, vaccine strategies. I also want to share how our health departments and the CDC conceptualizing how to get vaccine and allocate vaccine, and how are we using the vaccines. Of course, everyone is familiar with pre-exposure prophylaxis vaccination, administering a vaccine prior to exposure to a pathogen. And I'm sorry, my slide is empty here. It's currently only allocated to health departments and then passed on to clinical partners or as different jurisdictions see fit. There's also standard post-exposure prophylaxis, and vaccines can be used to administer to folks who are high-risk contacts. Generally, it's best done within 1 to 4 days after contact, but can be administered up to 14 days after exposure. And then sort of a new description of expanded post-exposure prophylaxis approach, or outbreak response, MPX, post-exposure prophylaxis, is really getting vaccine to people with certain risk factors that are more likely to have been exposed to someone with MPX, and aims to engage with that population, even if they haven't had a documented exposure with confirmed MPX. Next slide. So the $1 million question here, Baltimore City Jynneos availability. As you may be aware from the Baltimore Sun article, doses are allocated from the CDC to different jurisdictions, and there is an extremely limited supply. 200 doses were allocated in early July to Baltimore City, and these are allocated to traditional PEP that are provided through contact tracing investigations. Again, reaching out to ACD at BCHD if you encounter someone who would fall in that category. And then also for use at PEP, and I will say there will be a small amount available at the Baltimore City Health Department sexual health clinics. I've provided our website here to look at our hours, our phone number, and patients will be, we are asking that patients call to request this starting Monday. But again, there is a very limited supply. And then also there will be community partner events, which I can't, don't have time to speak about right now, but will be announced by the health department. So next slide. I'll pass it back off to maybe Matthew. And I think we have about 10 minutes, and there are just so many questions that I think need answering to address, to meet this moment of public health. And so I think we wanted to take a moment to perhaps address some questions in the chat, but also galvanize this group of researchers, clinicians to support the efforts to address monkeypox.
Thank you so much, Liz. Thanks to everyone for their great presentations. This slide was just sort of my thoughts in 5 minutes, with very little discussion with anyone else. So please indulge me on this. I think there's, as Liz said, there's a huge amount of different areas that are ripe for research, as well as clinical implementation science. One of the hoped outcomes from this presentation is that we could coalesce as a group of people at Hopkins who were interested in working on things related to monkeypox, including basic science through to education. So I'll stop talking now. I've tried to keep up with some of the questions in the chat, but I'd really welcome discussion and comments from the floor.
There's a question in the chat, Liz, about how you all are following up on the evaluations for people for whom you prescribed tecovirimat.
Yeah, so from my one experience so far, which is an N of one, I've connected with the patient to do a telemedicine visit. The CDC has said that that's acceptable, does not need to be a video visit. It really is just a basically a front back page that essentially comments on physically how are they doing, are there new lesions, and are they continuing on with therapy? And so the CDC has acknowledged that that's, providers are strapped, but generally it's a pretty straightforward process, and that form is then, sent back to the CDC.
And Greg Lucas has asked how EPEP differs from PrEP. I think that is, again, it's a really important question. People with more information than me will have different opinions, I'm sure, but it seems to be semantics. At least to my mind, it's a way of trying to justify offering immunization to different people at risk.
I have a question for Dr. Blythe. Dr. Blythe, thank you for being on this call and again for leading the efforts here in Maryland. With the tecovirimat prescription, is it correct are you the person approving? Are there others with you? And is the phone call the best way to request treatment?
Well, the actual approval comes from what's called the CDC clinical team for at least when there is a specific individual patient request. And we can talk and should talk more about having a supply of tecovirimat sort of basically pre-positioned at Hopkins, because you guys are increasingly, and I think rightly, treating people. So we'll want to figure out how to make that work in a sustainable way. So I think that's where we'll probably want to go. However, that said, yes, if you guys reach out to me, at least for these individual patient requests, what we do is then briefly summarize the situation for the CDC clinical team. That team then approves or disapproves, so they have not disapproved any requests to date. But anyway, approves the request, and then they submit that approval to the Strategic National Stockpile, which is the group or the entity that actually has tecovirimat, and then they work out the shipping arrangements. So that's the process, and that's what's in place right now, though we can, again, discuss having a supply of tecovirimat there at your pharmacy, and then I think the process would be different. It would be sort of an internal approval.
Great. And I know, Kelly, you've been involved. Kelly Dooley, your hand is raised. You've been involved in this and talked to Dr. Blythe already, so thank you.
Yeah, just some of the logistics after. So after he says that it makes sense to treat this patient based on the clinical scenario, then you have to submit a 1572, you have to do a consent process with, you have to do a 1572, an intake case report form, and then you have to send the 1572 to Megan Singleton at the IRB. You have to send the case report to Craig Hendricks, who will then give approval for P&T committee that this person is eligible for treatment from a local regulatory like IRB standpoint. And then from there you can consent the patient, and it's like a 6-page consent form, and it involves bloods and follow-up visits and things like that. But the thing to know is that now they're developing in this moment consent forms that can be done electronically that are compliant with FDA requirements for electronic signatures, because people are isolated at home, they're not allowed to come. And how are you going to get a consent form, especially if someone doesn't even have a printer? It's really tricky. And then the other component is then once you get the consent form, the drug has already been shipped because David Blythe has organized that. And while the drug is on its way, you can do these other components. But then when the drug arrives, it's going to go to this 24-hour pharmacy here, and then now they're organizing how to get it from the pharmacy to the patient, especially if the drug comes on a evening or weekend. So anyway, all those logistics are kind of in play, but I think hopefully that will all go away. Maybe the CDC will just change how access happens so that it doesn't have to be under this research protocol. But anyway, that's currently how it's standing. So just contact Megan Singleton if you have someone, because she'll know how all of this is evolving. That's all.
Yeah, and Kelly Gibo had recommended that I identify some providers at Bartlett who could become skilled at this. So I'm going to be reaching out to people to see if they'd be willing to be point people to, help do this for other providers until the, access changes. And then Dr. Blythe, I will definitely be reaching out to you about the logistics of having some medication on hand that would really simplify things for us here at Hopkins. But I just want to say thank you to everybody who's been doing the work, because as you see patients, as you prescribe, we're learning the processes that we need to put in place.
I just want to say a huge thank you to the teams who have been involved. These were great presentations, and having seen several of these cases at this point, I think we've gotten much better in the clinic at doing the testing and getting that to the lab. Heba, your team has been terrific in terms of getting the results back quickly, and I think we've gotten better at both informing patients of what's going to happen before they arrive, as well as kind of helping them understand what's going to happen after they leave. One caveat I will notice is that we have had several patients who have progressed after they have left, so may not have been thought to be indicated for treatment, but then developed tenesmus or mucosal lesions. And so I do think it's important for us to continue to follow them. And then, a treatment decision might not be made immediately. The other issue obviously is going to be this vaccination and of contacts and the best ways to allocate those vaccines. I do think us thinking about some of the household contacts who are, a higher risk for this might be important for us to consider. And I certainly am not involved in the vaccine allocation, but know that there's going to be a number of patients at home who have family members who have comorbidities we might want to think about.
Well, thank you, everyone. Well, thank you for that final closing comments, Kelly. I think that the vaccine distribution and equity are, huge areas that require a lot of work, and they're still at very early stages of discussion. I would like to thank everyone for being here, for taking part, and for everybody who has spoken and shared their expertise. And special thanks to Dr. Blythe for taking time out of his doubtless hectic schedule to spend some time with us this afternoon.
Thanks, everyone.
Have a great weekend.
Bye-bye.
Bye-bye.
Thank you so much.